Good evening, everybody. So welcome to case-based discussion organized by PeMSAA. Today we have our speaker today. She doesn't need an introduction to most of you. She is Dr. Priyanga Dematawa. So it's currently attached to the alumnus of Peradeniya Medical School. And she'll be talking about a neonate with convulsions followed by MCQ. So without much ado, let me hand over to Dr. Priyanga. Priyanga, over to you.
Thank you very much, sir. Good evening, everybody. It's a pleasure to be a part of alumni giving a helping hand. So we are going to start with our CLD followed by MCQs. Probably this session will be over by the MCQs. We'll see how things going on. Let me share my screen. Though the introduction says it's a neonate, just a bit past a neonatal age. This is a baby of 5 months old. Sorry, 6 weeks old baby from Peradeniya brought to A&E with poor feeding and poor activity for 2 days duration with an episode of abnormal movements. So this is a 6-week-old baby. It's a baby boy from Peradeniya with poor feeding and poor activity for 2 days with abnormal movements. I'm happy if you can quickly think of, okay, what are the possibilities? And if you can ask questions from me, so we can spend 5 to 6 minutes just to clarify the history. Anyone would like to elaborate the history of presenting complaint?
Madam.
Hello.
Oh, madam, whether the baby had fever?
There's no history of fever. It's a very good question, but baby didn't have any fever.
Madam, I would like to know more about the abnormal movements, like what is the character?
It's a movement involving left upper limb, only left upper limb tonic movements.
Madam, were the babies well looking or ill looking?
It was very ill child. Baby was ill on admission.
Madam, how long the movements persist?
So mother has brought, they were very close to the hospital, so they brought child 10 to 15 minutes. Throughout that period, they have noted abnormal movements, even on admission movements there.
Madam, was the child responsive or non-responsive during the period?
So child was drowsy.
Madam, the history it mentioned there's a poor feeding. So I wanted to know the what and the how is whether it's the problem with the mother or the
No.
and has both babies breastfed adequately, right? The mother's breast emptiness and the weight gain. So those
Mother
parameters.
has felt babies are feeding really well, kind of, but there was a discrepancy of the weight. This baby is 1.9 at birth, and the estimated kind of weight was, because the previous measurement was 2.1 at 4 weeks. So there's no adequate weight gain as such for the baby.
Madam, is the other twin completely normal and growing well? And
Sorry?
is the other twin completely well and growing normally?
Yes.
Madam, is this the first episode?
Yes.
umbilical.
Madam, what about the immediate postnatal period?
Both these babies, so elective section at 35 weeks because of the twin pregnancy, both have been kept with the mother in the ward. There were no hypoglycemic episodes, and they have breastfed from the beginning, apart from jaundice developed on day 3, and where we have given in-ward phototherapy for 3 days. Otherwise, no significant problem during the early neonatal period. In fact, we have discharged from hospital day 8 after stab weeks. And
Yes, madam.
according to mother, there's no upper respiratory symptoms.
Madam, any history of trauma?
Mother deny any history of trauma.
Madam, anything significant in the antenatal period of the pregnancy?
No, this is a IVF pregnancy because of the subfertility. So all the screen has been done, which is normal. No maternal illnesses during pregnancy. Mother was not on any drugs during the pregnancy, and all the scans had been normal.
Madam, after the birth, the baby's weight is faltering or no?
Initial weight faltering was there, where the discharge weight was somewhere around 50 grams below the birth weight. Then we have got the baby down on day 14. There had been a weight gain, but it's not really adequate, kind of roughly about 8 to 10 grams per day. Weight gain had been there. At the end of 1 month, weight was 2.1 kilos and baby was 1.9 at the time of birth.
Excuse me, madam. Madam, one question is regarding the abnormal movement. Has it occurred while the child is on sleep or awake condition?
Actually, mother has tried to put the baby breast again. During that time, mother has noticed these abnormal movements.
Madam, what happened to the baby after this episode of abnormal movements?
What happened to the baby after the abnormal movements? So the movements was continuing at the time of admission. Baby was non-responsive baby with abnormal movements, the jerky movements of the left upper limb. So as I already said, it's apparently well child who was exclusively breastfed, noted with poor feeding and activity, no fever. It was clonic movements involving left side upper limb, which have been continued for about 10 to 15 minutes, and they have noted drowsiness with the episode. And this is the birth history. Shall we move to the examination?
Okay, madam.
Yes, what do you want to know?
Any port one is done?
No? Why port pine stay? Because of unilateral convulsions. Fine.
Any bulging fontanelle?
Yes, the fontanelle is bulging tense fontanelle.
Any ear discharges?
No. If you do the examination in order, I'm sure you're not going to miss anything.
Madam, what are the
What about the
anthropometric measurements, madam?
respiratory system?
We were able only to, get the rough weight measurement, which was on admission also 2.15 lakh. So it's almost same like.
Blood pressure?
We couldn't record the blood pressure.
Madam, OFC.
Actually, we didn't measure the OFC at that point, but after that, OFC has gone, rapidly increased. OFC is noted. Because we examined this baby at 4 weeks of age. Within that week, there had been 1.5 lakh increment during the time of admission.
Madam, is there any syndromic features in the?
No.
Madam, is still baby icteric?
Still in the sense at the time of admission, yes. Baba
Yes.
was, yes, baby was icteric.
Is it mild or?
Now, we felt the icterus of the sclera, but if you look carefully whether there was a tinge of icterus in the skin as well, especially the mucous membranes. But babies, the complexion already dark, because of that probably it has mass, but there was significant icterus in the sclera.
What about the vitals, madam?
What do you mean by vitals? All the parameters?
Pulse rate, respiratory rate.
Pulse rate for baby has marked tachycardia with steady pulse.
Respiratory findings.
Respiratory rate around 24 line with irregular breathing.
Any abnormalities detected in the cardiovascular examinations like murmurs?
There were no murmurs as such. It's mainly the low volume pulse with tachycardia.
Was the liver palpable, madam?
Yes, it was 3 centimeters because the posterior margin with normal upper border.
Madam, the spleen also palpable or not?
There was no splenomegaly.
Any documented temperature rise?
No. Actually, baby was hypothermic. Some, the general findings, some no in general examination. The baby doesn't have any skin dysmorphic features, is icteric.
Any edema, madam?
No edema.
Evidence of dehydration?
No.
Madam, whether baby is pale or not?
In urine color.
Significant pallor was there. Significant pallor was there.
Any, madam, bleeding manifestations?
There were no the obvious bleeding as such. We couldn't find any obvious bleeding from the baby.
Is there any change in urine color?
Mother has not noticed. She didn't realize whether the color has changed or not.
How about the reflexes, madam?
Reflexes, the baby was hypotonic. Actually, we didn't elicit reflexes on admission, but baby was hypotonic.
Madam, you mentioned the all the skins also involved as icteric parts, and so I want to know whether it has involved with the peripheral limbs like the palm, sole. Has
No,
it in
not
that
up to the
extent?
palms and soles, but that tinge of icterus was there, especially the face. And if you look very carefully, the mucous membranes also with tinge of icterus was there.
Any cyanosis, madam?
No. No cyanosis, but skin, there was skin mottling. If you see that the lacework kind of that was there.
Madam, was it a consanguineous marriage?
No. There was distant consanguineous, but not close consanguineous. There's a history of consanguinity, but it's very distant kind of consanguinity. Okay, shall we go to the findings? You got this finding. So marked pallor was there. It was a mottled skin. No skin rashes. Baby was icteric. No significant edema. And there was actually low respiratory rate, which was irregular without added sounds. Peripheries were cold with significantly delayed capillary refilling time with tachycardia and steady pulse. We could detect the blood pressure. Baby was drowsy, was still convulsing on admission with bulging fontanelle. So if you have received this baby, what do you want to do at this point? If you are the doctor who's receiving this baby, what do you want to do now?
Fundoscopy to confirm the increased intracranial pressure, madam.
Do you think it's needed in this baby? Have you seen that we tried fundoscopy to check the raised intracranial pressure in this baby? Is almost kind of neonate still.
Ultrasound brain, madam?
Yes, urgent ultrasound brain would do. Don't you want to do anything for this airway breathing and circulation now? Now you have an acutely ill child who has come.
Resuscitation of the baby, madam?
Yes, I think that's a must now. Yes, I agree with you. You need imaging, but before that, I think you have to stabilize this baby. How are you going to do it? It's really fun. Yes. Probably you are going to assess airway, breathing and circulation. Then child is having tachycardia with steady pulses with markedly prolonged capillary filling time and is still convulsing.
We have to place the baby.
I told you it's a 24, almost
Immediately into a neonatal warmer and connect the baby to a pulse oximeter. and check the saturation and give oxygen nasal prompt.
Yes.
And IV access if possible, and capillary blood sugar.
Yes.
And
it's not if possible. Now you have to gain IV access, and with, at least with the drop of blood, yes, I agree, you have to do the capillary blood sugar, which was actually high in this baby.
with IV access, we have to get the full blood count, CRP, and blood cultures if possible. Send serum electrolytes, and since the fontanelles are bulging, we can start suspecting of a meningitis.
Yes, I completely agree with you. So you do the initial management, and then we go for the further management. I don't think that this baby can stay only with nasal prong oxygen. Probably this baby need intubation at that point. Actually, what happened was intubated, and we sedate the baby with midazolam, which controls the convulsion as well. And this is the baby's summary. It's a 5-week-old, first of DCDA twins, delivered by elective section at 35 weeks of POA with birth weight of 1.9 kilos, who presents with poor feeding activity and circulatory collapse. Marked pallor was there and is icteric with firm hepatomegaly and drowsy with bulging anterior fontanelle. Okay, what are the problems you identified now? Baba is stabilized. So what are the problems you have identified in this baby?
Yes, signs of increased intracranial pressure, madam.
Yes. Yes, signs of increased intracranial pressure. What else is there?
Focal convulsion.
Yes, focal convulsion is there.
Marked icterus.
Icterus is there with hepatomegaly, yes.
Hypovolemia.
Hypovolemia is there.
And anemia.
Anemia is there, good.
Growth faltering is there, madam.
Growth faltering is there. So there's something is going on now. And you have done all these things. And you are getting your blood investigations. In fact, in the full blood count, the white count was normal, platelet was normal, and HP was 6.7. It's 6.7 on admission. CRP was normal, blood sugar was normal, electrolyte normal. We did a BBG which showed metabolic acidosis. Now, the initial investigations we did, the only positive finding we got was anemia, but the platelet count and white count is normal, and there's no evidence of infection with high CRP. And we couldn't find any electrolyte imbalance as a cause for this convulsion. Now, one wanted to do ultrasound scan of the brain. Yes, we did an urgent ultrasound scan of the brain. What do you expect?
The baby is probably having an ICH, man.
It's probably having an ICH. You can see, ultrasound scan brain immediately followed by conductive as a hyperdense area involving the
liver failure causing coagulopathy.
Yes, that is more likely in this baby, a form of liver failure causing coagulopathy. If it's so, what further investigations you ask for? Now, this can be meningitis with a presenting complaint. Someone asked about the history of trauma. Yes, it can be trauma or non-accidental injury. Everything combined together, yes, it can be coagulopathy with liver failure. So those are the possibilities. Keeping everything in mind, what further investigations you would ask for?
PT and APTT.
Yes, both were markedly elevated. What else you want to know?
Liver enzymes.
Yes, they were elevated.
Ultrasound scan abdomen.
It showed hepatomegaly and mild splenomegaly with increased echo. Can anyone comment about this one, this bilirubin?
He's having an indirect hypobilirubinemia, madam.
Is it indirect or direct? You have to tell me.
Direct hypobilirubinemia.
It's direct hyperbilirubinemia. Why do you say it's direct? Anyone?
It is the proportion in between the both indirect and direct.
So it's something
More
like, yes, more than
20% of the
20% of the total. If the direct fraction is more than 20% of the total, so if you take 20%, it should be somewhere around 25, 26. But here you have, you have almost double kind of, or 1/3 like. So it's direct hyperbilirubinemia with increased liver enzyme. So what do you suspect now?
this can be
It can be the polystatic type of jaundice.
Yes, so either, but given that name, so if you, when you take the cholestatic jaundice, there are two, the intrahepatic and extrahepatic. So this
can be biliary atresia causing.
I told you the gallbladder was visualized.
Yes. Then it's extrahepatic.
It's intrahepatic. Your biliary atresia is extrahepatic.
Yes, ma'am.
So it's probably this is a neonatal hepatitis where we have to find the possible cause. Now, can any of you give the complete diagnosis for this baby? Now you know the story, you know the clinical findings and the investigation findings, and you have now rough idea probably what has happened to this child. So what is the most likely diagnosis? So if you want to give complete diagnosis for this baby, you can tell part by part and we can connect it nicely.
Intracranial hemorrhage.
Yes, good.
Due to the coagulopathy. secondary to liver failure due to neonatal hepatitis.
Yes, good. So what do you call this one? Now you have a baby with coagulopathy due to liver problems. What is the entity we are dealing with now?
Hemorrhagic disease of newborn.
This is the hemorrhagic disease of newborn. So this is a baby who had hemorrhagic disease of newborn due to neonatal hepatitis. Still we couldn't find the possible cause for the hepatitis, but who came with hemorrhagic shock following right side intracranial hemorrhage. So that is this baby. I'll quickly go through the what is this hemorrhagic disease of newborn. Actually, it's sometimes a life-threatening condition, and you know it's due to insufficient vitamin K, which do the carboxylation of coagulation factor 2, 7, 9 and 10. That's why both APTT and PT get affected. So if you can remember, yes, it affects both intrinsic and extrinsic pathway and the common pathway, giving abnormal values for your APTT and PT. With that you can differentiate. If this is being a boy, can it be a hemophilia? Yes. They also present with bleeding, but the clotting profile will say it's unlikely because both PT and APTT has increased. Now, hemorrhagic disease of newborn we categorize based on the age of onset. You know early and classic, but when it comes to late, so early occurs within first 24 hours. This is very rare. It's mainly with the maternal drugs which prevent vitamin K synthesis. The common one is the classic one, that is within the first week, that is after 24 hours until 7th day, the very first week. Late onset is after that, but there are two schools of thoughts. The earlier they took it as from 8 days up to 6 months, but later the newest definition is from 1 month after that. But there's a gray area from first week to up to 1 month. At that point, initial first 2 weeks, it is still can be due to classic hemorrhagic disease of newborn, which is common in most of the newborn breastfed babies. The late onset one, yes, it's very unlikely to present within very first 2 weeks. Why? The liver needs bit more time to manifest its findings. Probably because of that, they have moved the definition from 1 month, classic one and late one. Classic one is due to inadequate production of vitamin K plus the breast milk is a poor source of vitamin K. Most of the time they present with umbilical bleeding. Late onset hemorrhagic disease of newborn, most of the time due to chronic liver disease. So how are you going to evaluate? It's mainly depending on the time of presentation. If it's early, yes, maternal drug history is very important. And gestation is very important. Why? Preterm babies they have a higher risk compared to term babies. And feeding type. Because breastfeed babies get more affected compared to formula fed babies. Because formula is fortified with all these vitamins. So they are less risk. And whether we have given vitamin K prophylaxis at birth is important to know. When it comes to the manifestations, yes, they can bleed from any organ, but at birth, it's common to have scalp bleeding like cephalhematoma or subgaleal hematoma. But all cephalhematoma is not due to vitamin K deficiency. But if you see a baby with bilateral cephalhematomas, you have to have a bit of suspicion. The commonest way of presentation of this umbilical stump bleeding is the one with classic hemorrhagic disease of newborn. It's a common kind of presentation. Then both of these have significant hemorrhage, the intracranial hemorrhage, which cause morbidity and mortality sometimes. They can have intrathoracic hemorrhage, GI, they can bleed at any point, but umbilical stump bleeding and intracranial in severe cases are common. So how are we going to investigate? Yes, as you correctly mentioned, imaging is very important. Plus, you do the full count. The most important thing is you can see normal platelet. That is a very good clue for the diagnosis. Why? Even thrombocytopenia in newborn period can cause intracranial bleeding. But here, the platelet count is normal and they have markedly deranged clotting profile. But important thing is, if you do the D-dimers, it's normal. So the DIC picture is not there. So how do you manage? You repeat the vitamin K if it's a classic one and with the mild umbilical bleeding. In severe cases, you need FFP and you need supportive care and specific management depending on the underlying cause. It's mainly for the late onset hemorrhagic disease of newborn because neonatal hepatitis can be for the underlying cause. So what happened to our baby? We gave the ventilatory support for the baby and we give blood transfusion and FFP transfusion. We did neurosurgical referral because that hematoma was quite massive with the compression of the brain. And they evacuated almost 85 ml of blood from the baby's brain, the intracranial area. Actually, this baby got arrested once during the time of surgery and passed away on day 2 of admission. Now, unfortunately, we haven't taken extra blood sample from the baby. So we have given blood transfusion and FFP transfusion. So even we took the blood for further investigation, it might not show the results. That was a learning point for us because if you happen to transfuse blood in an emergency situation in a newborn period, better have preserved sample, one EDTA and a serum sample, which we haven't done for this baby. What we did was we investigate the twin sister, but it's a sister, so she was asymptomatic and her investigations are normal. So still, for the cause for the hepatitis is unknown for this baby. Thank you. Do you have any questions? It's 46. By about 50, we can move to the MCQ session. Before that, do you have any questions? You can at least send to the chat box if you can't ask. No questions?
Madam,
Mhm.
is there any chance of kernicterus in the baby?
No. Why did you ask for the kernicterus? With the initial one? Oh, the unlikely one thing because of the age, the other one is the type of bilirubin.
Okay.
And you rarely heard of massive bleeding in bilirubin encephalopathy. I think for your level, with the presenting complaint, you nicely came for the differential diagnosis, whether this is infection, trauma, and with the bleeding. And take it from there and plan your further investigations depending on that. But you really built up it nicely. Are you fresh enough to go through the MCQs or do you need a tiny kind of break? So one has asked whether we can suspect CMV infection as the cause for hepatitis. Yes, you can suspect, but in that case, the full blood count should be, at least they have to have thrombocytopenia. And if it's an infection like CMV, it's very unlikely only one twin affected, though they are DCDA. Being an infection, that was the doubt. And mainly the full count was completely normal and there were no other manifestations of the CMV. Plus, this is an IVF pregnancy. They have done full workup because of IVF. So there were no evidence of CMV infection in the mother. Which route should use for repeat vitamin K therapy? Again, the IM injection weekly. Shall we start MCQ? Are you there?
Yes, madam.
Yes. So shall we do something like this? I have 10 MCQs and 5 single based answers. Shall I give about 1 minute for you to quickly go through the question and answer on your own and discuss this at the same time? And move to the next one. Shall we do
Okay,
something?
madam.
Okay, to start with. My screen is not moving. So I start my timer. Okay. Clinical features occur up to 48 hours after the incident. Is it? True
Yes,
or
ma'am.
false? Yes. Response excessively to stimulation in mild disease. Do you know in hypoxic ischemic encephalopathy, we categorize encephalopathy to mild, moderate, and severe. In mild disease, they say excessive response to stimulation.
True, madam.
It's true. If you look, they are very hyper alert. Normally, newborns sleep for a longer period. No, these babies are hyper alert babies and they have a excessive stimulation. Even the jitteriness is marked. Yes, it's right. Seizures characteristically occur in all grades.
False, madam.
It's false. Why?
In mild form, it is not there, seizures.
Yes, mild form, it's not there. Yes, right. Has evidence of multi-organ involvement.
True, madam.
It's true. That's how you differentiate hypoxic ischemic encephalopathy from isolated intracranial pathologies. Because this hypoxia is not only for the brain, your heart affects, your lungs, more than that your renal, GI, all these organs are affected. So multi-organ involvement is there. Total body cooling or therapeutic hypothermia is the treatment.
True, madam.
True. So bit about therapeutic hypothermia, where you keep the baby in low temperature like 33.5 for 72 hours and do the gradual rewarming. This doesn't do anything for the already damaged areas, but it prevents reperfusion injury. So that's what it mainly does. Okay, we'll go for the second question. It's not moving. I don't. Give me a second. Huh? Sorry. Yes. Shall we discuss? Caput succedaneum commonly confined to parietal bone.
False, madam.
Why?
It's a soft tissue edema. It's
Yes,
not
so
confined to parietal bone.
and crossfit line. Yes, you're right. But what is the scalp lump that confined to parietal bone most of the time? Confined to a particular skull bone?
It's a cephal hematoma.
It's cephal hematoma. Because of the position. It's the. Then the second one.
Yeah, it's false, madam.
Why is false?
Because it confines to the bone, the blood loss is not amounting to shock.
Yes. There's tamponade defect and they can't get into that much. Yes. Cephal hematoma doesn't cause hypovolemic shock. What does can get up until causing hypovolemic shock?
It's
a soft tissue edema. It's not that much of bleeding.
Subaponeurotic hemorrhage.
Subaponeurotic or subgaleal hemorrhage. Number 3, the third response.
It's true, madam.
It's true. So they can give hypovolemic shock and coagulopathy. Fourth one.
It's true, madam.
Yes, it can cause them. It can be associated. Yes, it's true. Why? The same nerve root.
Yeah, it's involving C5, C6 nerve roots, madam, and can involve phrenic nerve also.
So it can involve phrenic nerve. Yes. Fifth.
False, madam.
Why?
Clavicle fractures usually heals on its own.
Clavicle fractures heals on your own, and you may really wonder, see, it's not only clavicular fractures, even long bone fractures, we don't do immobilization in newborns. It's just the tight plastering we don't do. Some problem with this one. Huh? Yes, we'll go for the third question. Yes. In respiratory distress syndrome, alveolar surface tension is high.
False.
Why?
because they are deficient in surfactant, which makes the surface tension low.
So what does it say? In respiratory distress syndrome, alveolar surface tension is high.
It's true, madam.
Yes.
Because there's no surfactant.
There's no surfactant because of that surface tension is high. That's why they go into atelectasis. When you read this kind of MCQ, better read all the time with the step rather than the response all the time. The first one you read, like in respiratory distress syndrome, alveolar surface tension is high. In respiratory distress syndrome, the clinical features appear early after delivery. Likewise, you try to read the whole sentence. Then the chances of missing is less. Now, whoever who answer first, you know the theory, but when it comes to the wording, that's what has happened. So be careful. Second one?
True, madam.
It's true. Third?
Third one's false, madam.
False because of?
We do not give
Don't give intravenous. So we give it?
Instead directly into the lungs.
Lungs. The fourth one?
It's true, madam.
Yes, true. We all the time try to do the non-invasive respiratory support because its trauma to lung is less. So whenever possible, we try to manage with CPAP. Then the fifth one?
True, madam.
True. Fine. So we'll go to the next question. You have to tell me why I can't straight away go to the next question.
Madam, can I ask a question? In this MCQ, madam, why didn't we take clinical features appear early after delivery as false?
Clinical features appear early after delivery? Yes. If it is respiratory distress, what happened?
Usually it occurs after 4 hours.
It's from the birth up. So it's very unlikely if a baby develops respiratory distress after 4 hours, it is very unlikely to be due to respiratory distress. That is the thing. So if surfactant is deficient, it's deficient from the beginning. So they have clinical features from the beginning and they should develop within first 4 hours. That's why we talk about this 4 hours. It appears within that 4 hours. That doesn't mean. So most of the time it appears early after delivery and if not within very first 4 hours. Have I answered your question? Shall we? Hypothermia in preterm infants. Neutral temperature is highest in early days of life. What is this neutral temperature?
The temperature where the newborns energy consumption is at a minimum level.
So where you have the minimal energy consumption. So neutral temperature is highest in early days of life.
It's true, madam.
It's true. That's why we try to keep them in an incubator with a high temperature with adequate humidity. Hypothermia in a preterm infant is a risk factor for mortality soon after birth. Can hypothermia per se kill the baby?
Yes, madam.
Hypothermia occurs as their skin is heat permeable.
True, madam.
It's true. Hypothermia causes hypoglycemia and hypoxia.
True, madam.
And even fifth one is, it's straightforward. Can be managed with kangaroo mother care. Especially mild hypothermia can be managed with mild kangaroo mother care. EON stands for early onset neonatal sepsis. It's a standard application. In neonatal infection, when I start talking, have you finished answering all these 5 steps? That is within 1.5 minutes, like, have you done the question?
Yes, sir.
Right. At least raise your hands, virtual raising of your hand, whoever who has done the question within that period. Okay. So the risk of EO, early onset neonatal sepsis, is increased with premature rupture of membrane. It's true.
True, madam.
Early onset listeria infection occurs as an ascending infection.
True, madam. False, madam.
It's false. It's not a common sense.
Yes.
From the mother's blood through the placenta. Two normal CRP values 24 hours apart are strong evidence against early onset neonatal sepsis. Excuse me for sorry. So two normal CRP values 24 hours apart are strong evidence against early onset neonatal sepsis.
It's true, madam.
It's true. Normally we do very first CRP with the initial blood sample, especially for suspected neonatal sepsis. It almost always like it's normal, but you have to have your second CRP, preferably 18 to 24 hours apart. If only both CRPs are normal, we can say this is negative. Having very first one only, which is negative, doesn't exclude your sepsis. Yes, hyperglycemia is a feature.
It's true, madam.
True, it can cause both hyperglycemia and hypoglycemia. Fifth one.
False, madam.
It's false. You never ever just manage with local antibiotics. You mask the infection. You apply it on top of this one. Yes, superficially it looks healed, but infections can spread underneath. So periumbilical skin inflammation, you don't manage with local antibiotics only. Like but you don't manage with local antibiotics. Yes, management of neonatal jaundice. We know the modes of management. We have phototherapy, we have exchange transfusion, we have one medical therapy, it's IVIG. So phototherapy uses blue-green band of visible spectrum.
True, madam.
True, madam.
Yes, it's true. Treatment threshold of phototherapy depends on gestational age.
True, madam.
What else it depends on? Does it depend on the postnatal age?
Yes, madam.
Yes. Does it depend on the level of serum bilirubin?
Yes, madam.
Yes. So those are the things that it depends on. There is no long-term sequelae of phototherapy.
True, madam.
True. In exchange transfusion, twice the blood volume of the baby is exchanged.
True, madam.
We normally do double volume exchange transfusion. After the double volume exchange transfusion, what is the expected reduction of the bilirubin? What is the expected reduction? It's 50%. At least you expect 50% of the bilirubin to come down. IVIG reduces the need for exchange transfusion in hemolytic disease of newborn.
True, madam.
It's true. You know what is hemolytic disease of newborn? It's antibody mediated. So with IVIG, you can reduce the antibody levels, which is a protective. Or you can reduce the need for exchange transfusion. Fine. In gastrointestinal disorders, antenatally undiagnosed tracheoesophageal fistula present with cyanotic episodes.
True, madam.
It's true because of the choking episodes with excessive secretion. Yes, they can present with cyanotic episodes. Meconium and amniotic fluid exclude small bowel obstruction.
It's false, madam.
False, madam.
Just by
There can be fistulas.
there can be fistulas, small bowel obstruction. There can be fistulas. More than that, meconium is
It is due to the maturation of the gut.
it's the maturation of gut. It's what is meconium made out of?
The epithelial debris of the large intestine.
Yes, it's mainly the epithelial debris, the secretions, and feces. So even small bowel is obstructed, large bowel itself shedded the epithelial cells. So there can be meconial obstruction. Normal plain abdominal X-ray in a baby with bilious vomiting include intestinal obstruction.
False, madam.
Why? What can't you exclude with just plain abdominal X-ray? What significant abdominal pathology or GI pathology that you can't exclude?
Malrotation.
It's malrotation. So with the twisting and untwisting, yes, sometimes your X-ray can be normal, but you need contrast studies to exclude. And the other thing, bilious vomiting is always abnormal. So if bilious vomiting is there, you have to look for the cause. It's almost always abnormal. So you have to look for the cause. Normally what we do is abdominal X-ray, but normal X-ray doesn't exclude intestinal obstruction due to malrotation. Fourth one, exomphalus carries a greater risk of dehydration and protein loss.
It's false, madam.
It falls. Probably someone has tried to just take you, out of the track. You should know these two pathologies. One is exomphalus, the other one is gastrochysis. You should know the differences and similarities. Dehydration and protein loss is common with what?
Gastrochysis.
Gastrochysis, which where there is no membrane. Then this one, the fifth one.
It's true, madam.
The other way around. Exomphalus is the one associated with congenital anomalies most of the time. Gastrochysis, most of the time it's an isolated finding. There's no associated congenital anomalies with, sorry for the spelling mistake, anomalies with gastrochysis. So that's what I told you. It's time differences, but make sure that you go through them and find out exactly what it is. Exomphalus covered with membrane, and it is the one which associated with congenital anomalies. Gastrochysis, no covering, simple, yes, bowel loops out. Once you insert them in, it's most of the time, if you develop intra-abdominal pressure and the problems, the ischemia, otherwise it's a straightforward kind of surgery. Okay. Necrotizing enterocolitis. It's common in preterm babies, yes. What is the first response? Incidence increases with increasing prematurity.
It's true.
It's true. What do you mean by increasing prematurity?
And why less of gestational
Premature. So it's increased incidence with increasing prematurity. Yes, right. The second response is very straightforward one. Risk is lower in infant feed with formula milk.
false?
Hmm?
It is false.
It's false. This is, no, it's not lower, it's high risk with cow's milk formula. Feed intolerance is an early sign.
True, madam.
It's true. That is the very difficult thing to diagnose. Why all these preterm babies, especially extreme preterm babies, have an entity called alleles of prematurity because of the immature gut. Anyway, they have kind of feed intolerance. So we don't know it is due to necrotizing enterocolitis, early phase, or feed intolerance. Because of that, we most of the time try to hold the feeds and see. So feed intolerance is an early sign. What are the other common ways of presentation? If otherwise normal preterm baby presents with apnea, late onset apnea is a feature. Just with unexplained thrombocytopenia, it can be. So there are so many ways of presentation before developing full-blown necrotizing enterocolitis. Intradural gas in the abdominal X-ray is characteristic.
True, madam.
Malabsorption is a long-term complication.
True, madam.
It's true. It may be due to surgery itself or the treatment itself. They can have malabsorption. Yes. Causes for sudden deterioration while on ventilator. So it's causes for sudden deterioration while on ventilator. Probably the causes they have given is almost all causes deterioration on ventilator. So what are the causes for sudden deterioration? Ventilator associated pneumonia? It's false. Why? It causes deterioration, but it's not a sudden one. It's not really kind of. Excessive endotracheal tube secretion.
True.
True, madam.
Tube block. Yes, block tube. Accidental extubation?
True, madam.
It's true. Pneumothorax?
True.
True, madam.
True. PPHN, persistent pulmonary hypertension?
False.
It's false. It doesn't cause sudden deterioration. So what is the mnemonic for this sudden deterioration?
Dope.
It's DOP, yes. Dislodgement, obstruction, pneumothorax and equipment failure. What else can cause deterioration or difficulty in weaning? It's mainly your PDA. Opening of PDA cause, again, deterioration, but it's not sudden. Pulmonary hemorrhage? If it's massive, it's sudden. So it's applicable for both gradual deterioration and sudden deterioration, pulmonary hemorrhage. So those are the causes for deterioration while on ventilator. Fine. Fluid and nutrition in preterm newborn. Fluid requirement will vary with gestational and chronological age. Chronological age? Yes, you know, the day 1 you start this amount, day 2 start this amount. Likewise, yes, postnatal age, the fluid requirement will vary. What about depending on the gestational age? Is there a difference?
No,
There is. So, late term, late preterm, they need less amount. Extreme preterm, normally we tell for preterm we start 80, but sometimes extreme preterm, especially ex-utero transfers, you need even higher volume, sometimes even 90 or 100 in day 1. So there's a difference between depending on the gestational age and chronological age. This statement is true. Fluid adjust according to serum electrolyte.
True.
It's true. So it's mainly depend on the serum electrolyte, urine output and weight gain. This 60, 90, 100 thing is now it's already calculated and given as a consensus agreement, but now the latest trend is to go with the electrolyte, urine output and weight change. If there's no significant weight loss, that is 2% or less is the weight loss with adequate urine output and no rising sodium where there's a marker of possible dehydration, we don't increase the fluid level, we can keep in the same level. They have done studies and show less fluid is much better for the lung recovery. 20-week baby double their birth weight in 6 weeks. You see? When do term babies double their birth weight? Term babies,
Mm, 4 to 5 months.
roughly yes, 3 to 4 months time. Preterm babies, do they have higher, rate of growth compared to term babies, preterms?
Yes, madam.
Yes, because they try to match the intrauterine growth. Yes, they double their birth weight in 6 weeks normally. It's true. In very preterm babies, enteral feeds should introduce after 48 hours. Any idea? It's false. It's false. It's not correct. It's a false statement. Those days, yes, we try to delay commencement of feeds, but you need a trophic feed to prime the gut. Now, with the studies they have shown, you have to start as early as possible, preferably with the maternal milk. If maternal breast milk not available, only the best next option is donor breast milk. And you try to avoid formula as much as possible in very preterm babies. And you have to commence it as soon as possible. Only in significant hypoxic events, we try to delay it until this lactate is normalizing. Otherwise, as soon as possible, you start enteral feeds even in very preterm babies. It's false. Fifth one, I'm sure you can do it.
It's true, madam.
It's true. So poor bone mineralization, what we call osteopenia of prematurity, it's mainly due to inadequate phosphate, and you need phosphate supplements. Best of 5 or the single best answer, shall we do it? Or it's enough? We'll do. Again, What is the
Dependent
dependent patient, you be more specific. What is the possible diagnosis? There's a one thing for you for the possible diagnosis. It's more likely critical path patient by even after resuscitation, yes, baby has presented else can you use instead of ibuprofen?
Paracetamol.
Paracetamol. Okay, what is the diagnosis here?
Umbilical granuloma.
It's umbilical granuloma. So what do you want to do? What is the Staphylococcus epidermidis?
It's a skin commencer.
It's a skin commencer, so you don't have to do anything with that. So what is your plan for this baby?
We can cauterize with copper sulfate.
We can cauterize this baby. Decauterize with copper sulfate. So what else you can use for cauterization?
Silver nitrate.
Yes, you can use silver nitrate. Okay, what is the diagnosis?
Congenital hypertrophic pyloric stenosis.
What is the clue for the diagnosis in the stem?
Metabolic alkalosis.
Metabolic alkalosis. That is the one which give alkalosis because of HCl loss. And most of the diarrheas, what does it cause in any baby, especially newborns? Diarrhea cause? Is it alkalosis or acidosis?
Acidosis due to bicarbonate.
It's acidosis due to bicarbonate loss. Yes. It's a very simple kind of question, isn't it? What is the diagnosis? What do you want to do?
The baby is hypoglycemic.
Yes. So you have a convulsing baby with hypoglycemia. Now probably you really feel, okay, what to do now? We to give the dextrose or midazolam?
The dextrose.
Dextrose. So you have to correct the correctable causes. If it's hypoglycemic convulsion, no point of giving anticonvulsants. You have to go for dextrose bolus. What is the bolus dose?
So 10%, 3 to 5 milliliter per kg.
3 to 5 calories to 2 to 3. Normally what they say is 2 to 3 ml of 10% dextrose is the bolus. Last question. I'm so happy. This So what is your diagnosis? What is more likely in this baby?
Hypovolemia due to blood loss.
Hypovolemia due to blood. This is more likely. So what do you want to do now? You want to do the volume expansion. With what? That's what you have to think of. With what? On within what is with what duration as well. So what you want to do is blood or normal state.
And the most appropriate is blood, but in the acute, it's normal.
It's normal, and yes, now. Does it indicate an acute setup? Really acute kind of? What does it say now? Baba is impending kind of shock.
The baby has cold periodics and the
All periodic
marked here.
marked tachycardia. So you can't go blood to go normal saline. Dose is 5-10 ml per kg. Is it a rapid one or a slow bolus? It's a rapid push. If you're going to take 60 minutes for this one, it's a disaster. So it should be a rapid push of normal saline immunity. The textbook, we try to prepare as much as possible.
Looks like there are no questions, Priyanga.
Yes, sir. Then?
Yeah. Shall we then call it a day?
Yes, sir.
Yeah, fine. So, so thank you very much, Priyanga, for the comprehensive discussion followed by the MCQs. I'm sure students have gained a lot from that, and you have discussed around the questions as well. So students have a good idea what to study and then prepare for the. So on behalf of PeMSAA, let me thank Dr. Priyanga for her time and energy in preparing this presentation and then spending the time with you. So thank you very much, students. So we'll meet up again next week then. Okay, good night. All the best.